Good evening, everyone. My name is Dr. Satish. I'm working as a consultant in emergency department at Yashoda Hospital, Secunderabad branch. I welcome all the participants for the webinar on today's topic, red flags and right moves, evolving your DKA management. DKA, diabetic ketoacidosis, is a common medical emergency in type 1 diabetics seen in emergency department. A prompt diagnosis and management not only saves the patient from the mortality, but also decreases the hospital stay of the patient. Every week, our emergency department of Yashoda Hospital comes up with an interesting topic on common emergencies encountered in ER to create awareness and also improve knowledge of our participants. Today, we have with us Dr. Nikhil Bhargav, who is working as a consultant in emergency department at Yashoda Hospital's Hitec City branch to discuss on the topic red flags and right moves evolving your DKA management. So I will over to Dr. Nikhil Bhargav.
Thank you for the warm welcome, sir. And it's a pleasure to be here today. And so today's topic will be discussing on right moves and red flags of DKA management. Hopefully, after this session, we'll definitely be able to improve our already existing practices, which are very good regarding DKA management. Let's go ahead. So, as described by Dr. Julius Dreshfield, diabetic ketoacidosis, it's an acute major life-threatening complication of diabetes. It usually is more commonly seen in type 1 diabetes than type 2. And but it is not uncommon that it happens in type 2. It is most common with type 1 though. So what happens? In DKA, it is an extreme metabolic state caused by insulin deficiency. It is defined as an acute state of severe uncontrolled diabetes associated with ketoacidosis, and it requires emergency treatment. It is a state of absolute or relative insulin deficiency and aggravated by ensuing hyperglycemia. So there is the classic symptoms are usually hyperglycemia, there's dehydration and acidosis producing derangements in the intermediary metabolism. So this is the classical triad. So there are two definitions according to ADA, which is American Diabetes Association, defined in 2009. A glucose of more than 13.9 millimole per liter, that is around 250 milligram per deciliter, bicarbonate less than 18 and pH less than 7.3, and ketones positive for result, ketones positive in either urine or serum. In serum, what we generally happens is nitroprusside reaction. So that is the ADA guidelines. Whereas Joint British Diabetic Society, which we are going to focus more on today, and 2023 guidelines, which is revised from 2013 guidelines, you can see it clearly says glucose of more than 11 millimole per liter, that is around 200 milligram per deciliter, or known diabetes. Because why I'm stressing here with known diabetes is sometimes we can have euglycaemic DKA, which we'll be discussing later on. So, but classically, yes, more than 11 millimole per liter. And looking at ketones, a capillary concentration more than 3 millimole per liter or significant ketonuria by dipstick, like it's either 2+ or more. And then bicarbonate less than 15 millimole per liter or pH less than 7.3 or both. Notice how they say either one or both. So we are not going by single criteria alone here. So this is the definition by Joint British Diabetic Society. So epidemiology, if we discuss, this is roughly around prevalence around the similar in multiple countries, but roughly speaking, there's about 14% of all hospital admissions related to diabetes are DKA, and DKA is frequently observed in diagnosis of type 1 diabetes and often indicates this diagnosis. Like what happens is many of the times patients present with symptoms who are not a known diabetic, like this will be the incidental discovery that the person has diabetes, especially happens in type 1 diabetes. And how is the mortality? The mortality in DK is around at least 0.2 to 2%, and which is higher in countries like ours, which is basically a developing country. And the incidence of DK in developing countries is essentially higher, and it's far more common in younger patients. So when we look at pathophysiology, it's a complex disorder. So what happens is there's an absolute or relative insulin deficiency, like I have said earlier. And what happens is it is followed by an increase in counter-regulatory hormones. So there is a glucagon and there's a cortisol increase, there's a growth hormone increase, epinephrine. So basically what happens is all the counter regulation mechanisms fail, and this causes a shoot in the sugar. So this imbalance enhances what we have: hepatic gluconeogenesis that happens, we have glycogenolysis that happens, we have lipolysis and ketogenesis. Essentially all factors that is causing the sugars to go up, like in a very rapid and a very high state. So this is how it generally is. So there is an absolute insulin deficiency that is causing increased lipolysis, free fatty acids, ketogenesis increases. Again, alkali reserves reduce, and that itself again will cause ketoacidosis. And in case of a counter-regulatory hormone failure, you can see the protein synthesis goes down and proteolysis goes up. And what also happens is when protein synthesis decreases, there is an increase in gluconeogenic substrates causing gluconeogenesis. Or else if there is again ketogenesis is there, again it causes glycogenolysis, and ultimately all the pathways they result in hyperglycemia, glucosuria, which can cause osmotic diuresis, and there is a lots of water and electrolytes. Again, there is, because of all these things, there is a possibility of decreased fluid intake causing further hyperosmolarity. There's dehydration and impaired renal function. You can see here I've written two components, DKA and HHS, hyperosmolar hyperglycemic state and DKA, and usually there is this overlapping of symptoms. So a diagnosis is clearly important. So the differentiating factor is more of ketoacidosis in DKA and more of hyperosmolarity in HHS. It is important to differentiate, but again, the management is also slightly different. But we are going to focus on DKA today. So etiology, what happens is most commonly it can be inadequate insulin treatment, or there can be a possibility of non-compliance with the treatment that is already been prescribed by the endocrinology. And there is a new onset diabetes in almost as much as up to a fourth of the cases. That is almost 20 to 25%. They don't know they have the disease. They present with the symptom to the Department of Emergency Medicine, and that is when they're diagnosed. And when you look at acute illness, yes, it can happen. Infections can also trigger most of the time. So you can see infections and new onset diabetes are the most common things you can look at. Then there's also possibility of CVA, other myocardial infarctions, pancreatitis, but these are all relatively rarer factors triggering it. And next thing we need to look at is drugs that can cause decay. That could be clozapine or olanzapine, cocaine, which is a recreational drug that can be given, lithium, and then SGLT2 inhibitors and terbutaline we have. And clinical presentations, usually decay evolves rapidly over 24-hour period. So it's a very rapidly developing disease. So earlier symptoms should be like diabetes, like polyuria, polydipsia, and I'm sorry, one second. Yeah. Uh, uh, Weight loss. So there's nausea, vomiting, and abdominal pain are usually also present, and there can be malaise and generalized weakness and easy fatigability is also there. And as the duration of hyperglycemia progresses, you can see there's a neurological symptoms also can start. Neurological symptoms can start, and then they start getting lethargic. There are focal signs, and sometimes at presentation, even the patient can be very upturned. It is uncommon to find frank coma, which is more a sign of hyperosmolar hyperglycemic state, right? And next thing would be, these are the signs. See, we can look at signs and we can look at symptoms. So what are the normal signs you can see is generalized ill appearance can be there. There'll be labored breathing pattern. This is basic classic acidotic breathing, Kussmaul's breathing. And there'll be dry mucous membrane, dry skins, and the skin turgor is reduced. The reflexes are reduced. There is a characteristic ketotic breath odor. Like if you have ever smelled acetone, you will know how ketotic breath is. So it is similar to that. There can be tachycardia. Hypotension is one of the common symptoms that you can see. Tachypnea will be there because they're trying to compensate the acidosis, and there can be fever if infection is a trigger for decay, and then there can be hypothermia also. And later on, confusion and coma can develop, and they'll also have abdominal tenderness. Notice I'm saying tenderness because we're talking about signs. In the symptoms, yes, we can definitely talk about abdominal pain here. Right. So moving on. So how do we evaluate? So laboratory evaluation, what we have to do is at presentation, we'll be checking glucose, and then nearby every 1 to 2 hours, we'll be checking ABG or VBG. One of those definitely will help. Serum electrolytes, and preferably, if possible, can do phosphate. And renal function test will be doing urine dipstick test to check for ketones and everything else. Serum ketones, if available, is a good indicator and faster. One thing is important is serum ketones. It is better to do because two factors we have here. Most of the patients presenting with diabetic ketoacidosis, they tend to also be very, very dehydrated. And let's just say sometimes the urine output is very reduced. And when there is no urine output, it becomes difficult for a dipstick, and therefore, what it can do is delay our diagnosis. So serum ketones can help. Capillary serum ketones can be done easily these days. Yeah, we'll do a CBC just to make sure if there's any infective factors triggering it. Anion gap will help us. Osmolarity has to be done. Cultures have to be sent in case of any suspicion of infections triggering decay, and amylase if required. And so important thing is need to repeat investigations. Just because investigations are normal, if clinically it is warranted, please keep repeating investigations, so it will help us determine if we are missing any diagnosis, any alternative diagnosis, and most importantly, that our treatment is being effective or not. So these are the typical characteristics of DKA. So DKA will, you can have mild, moderate, and severe. Essentially, plasma glucose will remain similar in all the diseases, but what changes or what categorizes it as difficult or mild, moderate, or severe is we'll be looking at the pH. So 7.25 to 7.3 pH would be around mild, and 7 to 7.24 is moderate, and 7 is about severe. And ketones are positive in everything, but when you look at bicarbonates, 15 to 18, see, definition is by 18, at 18 it is less than 18 is decay, 15 to 18 is mild, 10 to 15 would be moderate, and anything less than 10, that is 10 milliequivalents per liter of bicarbonates, that is a very significant severe decay. Urine ketones are positive, serum ketones are positive. Again, it doesn't matter what level of positivity it is. The positivity level of ketones does not determine the severity of the disease. But again, we'll be looking at serum ketone range, though when you look at, 3 to 4 will be mild, and 4 to 8 is severe. Effective serum osmolality can be variable. It depends on multiple factors, so let's not dwell on that. Anion gap more than 10 is mild, more than 12 is moderate, and anything about 12 is severe. And if the person is alert, it would be a mild state. And whereas if the person is alert, drowsy, arousable, it could be moderate. Stuporous or obtunded or coma, that is basically severe decay, and which is comatose state is very, very low, rare, I mean. So what is the mainstay of management when you look at decay? So correction of fluid loss with IV fluids. There's a correction of hyperglycemia with insulin. Correction of electrolyte disturbances, particularly potassium loss. So then there's a correction of acid-base balance that needs to be done, and treatment of any concurrent infection or other factors if they're present. So when you look at typical deficit at presentation in DKA, based on different studies, the water deficit is at least usually 100 ml per kg. So if you take a 70 kg average adult, there is a deficit of almost 7 liters of fluid. That is very important thing to remember. That is why we aggressively hydrate them. Sodium is around 70 millimole per kg, and chlorides are around 3 to 5 millimole per kg. So is potassium, which is also around 3 to 5 millimole per kg. So you can see this is roughly around 600 6 liter water deficit. You lose at least this much. So this is the rough algorithm. So see, like you can see, the mainstay includes IV fluids, insulin, potassium, and we'll assess for any need for bicarbonate. So severe hypovolemia, again, the hydration status will be dependent on whether it is severe hypovolemia, mild hypovolemia, or cardiogenic shock. So based on which we will decide what fluid needs to be given. So again, we'll be looking at these things, hemodynamic monitoring, and all these things we'll have to do. Serum sodium monitoring has to be done continuously. And if the serum sodium is getting high due to high fluids, then you'll have to consider using 0.45% saline. So that again, it depends on, again, how much do you give depends on the volumic state, right? And if the serum glucose reaches 200 mg per dl, then you have to change to 5% dextrose with 0.45% NaCl. Insulin, again, usual dosage is around zero point 0.1 units per kg as IV bolus can be given. And but this, again, we'll be discussing on the newer guidelines, which has more, I mean, both can be done again, but what is the benefit, I'll tell you later. So infusion also starts at 0.1 units per kg per hour. And if it is uncomplicated, you can even give subcutaneous route. That is a good way to cut down costs, and in terms of efficacy also, it is very similar to IV insulins. Rapid acting insulins can also be given subcutaneously around zero point 0.2 units per kg every 2 hours. So if the target is if that 50 to 70 milligram per deciliter of the sugar doesn't fall within first 1 hour, then you keep doubling IV doses or subcutaneous boluses. You can give IV infusion at 0.1 units per hour with subcutaneous insulin boluses, right? And when it comes below 200 mg per dl, you can reduce to 0.05 units unit per kg per hour. Okay. We keep checking electrolytes, blood urea nitrates, venous pH. We keep checking creatinine, glucose every 2 to 4 hours until the person is completely stable. And we'll also be continuing IV insulin, even IV insulin for 1 to 2 hours after the subcutaneous insulin regimen is beginning. The reason is, what happens sometimes is when you suddenly stop IV insulin and just give subcutaneous insulin, there can be a sudden surge of sugars again. Regarding potassium, we have to make sure that the renal function is adequate. That is, how do we do is 0.5 ml per kg per hour, or at least tentatively 50 ml per hour. So if potassium is less than 3.3, we stop insulin and give potassium until potassium is more than 3.3 milliequivalents per liter. If potassium is more than 5.3, you don't need to give potassium, but we need to check on monitor potassium every 2 hours. This is the reason is because insulin causes reuptake of potassium. Therefore, what happens is there is a significant loss of potassium from the blood. So therefore, we need to make sure potassium levels are monitored as the treatment is ongoing. And regarding bicarbonate, there is debatable use, but if pH is less than 6.9, you can give 100 millimole per millimoles in 400 milliliters of water. And then 20 milligrams of KCl, we need to give it over 2 hours. But this has a debatable role. We'll be looking into it. If pH is more than 6.9, then there is no role of bicarbonates. So how do we correct fluid loss? Again, we'll be discussing this. It is one of the most important parts of treating patients with DKA. So we'll be using isotonic saline here, and 15 to 20 ml per kg per hour for the first few hours will be given. And then what usually happens is there's 1 to 3 liter of administration in the first hour, then 1 liter in the second hour, and 1 liter over 2 hours in the next, and then another 1 liter over every 4 hours. Again, this needs to be checked with degree of dehydration and CVP. One way of doing it one way of doing it apart from CVP is we can keep monitoring IVC status with point of care ultrasound, and then we can look into that. So when a patient becomes euvolemic, once the patient has, instead of hypovolemic, becomes euvolemic, immediately what we need to do is from 0.9% saline, that is isotonic saline, we switch to 0.4% saline. It is recommended, especially if you're thinking there's a possibility of hypernatremia. Insulin therapy is to be initiated only if potassium is more than 3.3 milliequivalents per liter, and intravenous regular insulin is preferred. But initiate with IV bolus of 0.1 units per kg followed by continuous infusion. Subcutaneous route can be used when there is an uncomplicated DKA. In that case, we can use 0.3 units per kg, then 0.2 units per kg 1 hour later. And when the serum glucose is reached less than 200 milligram per deciliter, then what we can do is we'll reduce the insulin infusion to 0.02 to 0.03 units or 0.05 units per kg per hour, and then switch IV saline to dextrose saline. next was normal saline. And we'll also be reverting to subcutaneous insulin, especially if the patient begins to eat. Okay, but we can give continued IV infusion for 1 to 2 hours. So this is the fixed rate intravenous insulin infusion, that is 0.1 units per kg of body weight is recommended. Why is it most important is insulin has these three effects. It suppresses the ketogenesis, it reduces the available blood glucose, and there's a correction of electrolyte disturbance. The insulin infusion is made up of 50 units of how we dilute is 50 units we use in 49.5 ml. Essentially, how we dilute to is 1 unit per ml. So this is on an average for a 70 kg adult. When you look at 0.1 units per kg per hour, if glucose is more than 14, so again, more than 14 as in more than 200 milligram per deciliter. So here you can see, depending on weight, you will give the dosages. But more than 150, it is better to involve the endocrinology as well. And if it is less than 14, again, this is the treatment regimen. Regarding potassium replacement, if the initial serum potassium is below 3.3 milliequivalents per liter, then potassium chloride IV is started, that is around 20 to 40 milliequivalents per hour in each bag. So if the initial serum potassium is between 3.3 and 5.3, IV KCl is around 20 to 30 milliequivalents, and it is continued till potassium concentration is around 4 to 5 milliequivalents per liter. If the serum potassium is greater than 5.5, you can stop potassium replacement. We don't want any hyperkalemia or its related complications. Regarding correction of acidosis, bicarbonates are usually, it's a debatable drug. So bicarbonate, it is a controversial drug. So what happens is they say give if arterial pH is less than 6.9. And in what you can do is you can give 100 milliequivalents of soda bicarb in 400 ml of sterile water. It can be given over 2 hours, and we need to repeat doses until the pH rises at 7. But most important thing is it has several potential harmful effects. It can trigger fluid overload state, it can cause cerebral edema, especially in the younger population, and it can also have potentially harmful effects like pulmonary edema. So what are the complications while treating DK? We can have cerebral venous thrombosis is one possibility, myocardial infarctions, deep vein thrombosis, acute gastric dilatation, erosive gastritis can happen, and there can be a possibility of late hypoglycemia, and respiratory distress can also happen. Infections as a consequence of DKA can also happen. It's while infections itself can trigger DKA, there are possibilities that DKA itself can cause infections. Hypophosphatemia is also a possibility, mucormycosis, cerebrovascular accidents, and cerebral edema, which is usually more common in the younger group of population. So this is regarding the protocols, but we'll again go through as a short basis. But these are the important topics to discuss which we have today. So whether we do ABG or VBG, whether we give bicarbonate therapy, when do we give insulin, and how much of a utility does insulin bolus have, and what insulin can be given and how much or how, and transition from IV to subcutaneous insulin, euglycaemic decay, which is not at all a myth, and most importantly, which fluid needs to be given. These are the most important discussion topics today, so that can definitely help us evolve our management of decay. So when we look at ABG or VBG, it is basically there is a study Kelly-Am et al. Done in 2006. So what happens is when you look at VBG or ABG, the pH between both are relatively similar. So we can use VBG as a therapeutic, sorry, as a diagnostic modality when we are doing a blood gas. So therefore you can use VBG. And most important is another thing, arterial blood gas. This was another test done by Ma Oj et al. In that ABG results, where some patients were done on ABG and some were done on VBG. ABG results rarely influenced emergency physicians' decision on diagnosis, treatment, or disposition of DKA patients. So that is an important factor. And venous pH correlated well, and it was precise enough with the arterial pH to serve as a substitute for ABG. Because we are not looking at oxygenation levels, we are mostly focusing on the pH levels and any electrolyte disturbances. If though there is an element of hypoxia, then ABG takes precedence over VBG. It will also help us to determine if there is any respiratory failure, if there's any CO2 washout, if there's an impending respiratory collapse, we'll know. So what happens is in ABG, I'm sure, it can cause radial artery spasm, infarcts or aneurysms and all these things. ABGs are very, very painful. I'm sure every single patient you have done an ABG on most likely has winced, at least winced. Some people even retract their hands in pain. So also another thing is, how many times have we done Allen's test? When was the last time we have done Allen's test while doing ABG? Yes, protocol dictates we do an Allen's test before taking an ABG. So if not, because it is not routinely practiced and there is some mishap and their circulation can be affected, can cause loss of limb as well. And then VBG electrolytes also another factor is almost 97.8% sensitive and 100% specific for the diagnosis in DKA as per Mensheen M et al. Study. So therefore, VBG is as effective as ABG and if not better in terms of patient comfort and economics. Okay, regarding the next contentious topic, we'll be discussing on bicarbonate therapy. So bicarbonate therapy study was done by Shua et al. In 2011. There is a transient improvement in metabolic acidosis when bicarbonate is given, but there is absolutely no effect on glycemic control, and there is a high risk of cerebral edema, especially in pediatric patients. And there are no studies done for patients with pH less than 6.85 by giving bicarbonates. Then intravenous sodium bicarbonate therapy in severely acidosis, according to Duhon et al. So there is no difference in time to resolution of acidemia. That's what they realized when you give bicarb or not. And there is no change in time to hospital discharge and how long the person needed insulin, potassium requirement in the first 24 hours. Subgroup analysis showed no statistical difference in the time of resolution of acidemia. Bottom line, see, intravenous bicarbonate therapy may be transiently, it may make acidemia better, but usually there is no improvement of glycemic control. What is important is on-time insulin, time to hospital discharge, and in children can worsen cerebral edema. So when do we give insulin? Insulin will be given as when hypokalemia is, hyperkalemia is there, we can give. And when hypokalemia is there, we need to stop intravenous insulins. In utility of insulin bolus, so the utility of initial bolus insulin treatment, according to Goel et al. Was done in 2010. What was seen is insulin bolus at the start of insulin infusion is equivalent to no insulin bolus at the start of insulin infusion. Essentially, what they're saying is there's no point trying to give bolus and then start infusion. It is better to start with infusion straight away. What happens is they have seen when you give bolus insulin and then give subcutaneous insulin, there is a decreased normalization of glucose, and also one thing is definitely it affects the rate of change of anion gap, and it can reduce ED or hospital length of stay. Insulin bolus given at the start of insulin infusion does. So what happens is there's an increased hypoglycemic events by 6-fold if we give subcutaneous insulin. So what insulin do we give? So give me 1 second. So yeah, what happens is what insulins can we give in the treatment of patients with diabetic acidosis? In a randomized control trial that was done by Amperes et al. In 2009, what they have done is they have given IV treatment with regular and glucine insulin. There was also a subcutaneous treatment protocol that was followed, which had regular insulin or NPH and glargine or glucine. What they found was both of them are, both IV and subcutaneous are equally effective in treatment of DKA. But what happened with glargine and glulisine is that the incidences of hypoglycemia kept coming down, especially when you give glargine or glulisine. Okay, so that is one of the important factors we need to remember when we are giving insulin. So low-dose insulin therapy by various routes by study by Fisher, Jane et al. So intravenous infusion of insulin is superior to subcutaneous route. So treatment of diabetic ketoacidosis with subcutaneous insulin apart. Again, this was done by Umpires et al. So what happens is subcutaneous insulin aspart when you give over every 1 to 2 hours, it is a safe and effective alternative to the use of IV regular insulin and in the management of patients with uncomplicated DKA. So there's another study, Umpires et al. In 2004, treatment of uncomplicated DKA with subcutaneous Lispro was given, and every hour in a non-intensive care setting may be safe, and it is usually more cost-effective than treatment with IV regular insulin and the intensive care unit. Subcutaneous Lispro and intravenous regular insulin treatments are equally effective and safe for the treatment of mild and moderate DKA in adult patients. So bottom line takeaway from here is treatment of mild and moderate DKA with subcutaneous insulin Lispro is equally effective and safe. So when do you switch from IV insulin to subcutaneous insulin? So what happens is, according to a study by O'Malley et al., first dose of subcutaneous insulin needs to be given at least 1 hour prior to discontinuation of IV insulin infusion, following which allows development of rapid rebound hyperglycemia, like we have discussed earlier. And the transition from IV to subcutaneous insulin, effectiveness and safety of a standardized protocol, it's a study done by Avananzini et al. So stable glucose. Stable blood glucoses which are less than 180 mg per dl for at least 4 to 6 hours and consecutively needs to be checked, and some studies sometimes even say 24 hours. There needs to be a minimal anion gap and resolution of acidosis in DKA. Stable clinical status, hemodynamic stability, not on vasopressors, stable nutrition plan or the patient is eating healthy, stable IV drip rates. So regarding euglycemic decay, it is not a myth, and it is not a myth, and usually glucose is less than 200 milligram per deciliter. Euglycemic decay is a rare entity that mostly covers in patients with type 1 diabetes, but is also rarely seen in type 2 diabetes. It has been associated with partial treatment of diabetes, carbohydrated food and food restrictions, alcohol intake, and sodium glucose co-transporter, that is SGLT2 inhibitor medications. And what was it? Glifosins can be used. And exact mechanism of euglycemic decay is not entirely known. So euglycemic decay is not a myth. It is essentially decay without the hyperglycemia. Euglycemic decay is a rare entity that mostly occurs in patients with type 1 diabetes, but it is also a little common in type 2 diabetes. It has been associated partial treatment of diabetes and carbohydrate food restriction, alcohol intake, and sodium glucose inhibitor and medications like glifosins, what was that? Canagliflozin and dapagliflozin, Jardans. These are all usually SGLT2 inhibitors. The exact mechanism, unfortunately, of euglycemic decay is not entirely understood. Euglycemic decay exists in patients who are not on SGLT2 inhibitors. That was done by Munro, JF, ET, and ET all. And vomiting was the most common symptoms what you can see, and most of the cases were type 1 diabetes in euglycemic decay. But the management remains same as DKA, but the insulin dosages change. There is also SGLT2 inhibitors that can cause, as per a study by Peters AL et al. So these are the mechanisms by which SGLT2 inhibitors cause. SGLT2 inhibitors can cause reduced glucose. So when there's reduced glucose, the insulin is reduced, and it can also cause increased lipolysis and free fatty acid increase. Beta oxidation is increased, and therefore ketone productions also has increased. Whereas when you look at glucagon, and reduced glucose can also cause increased glucagon increase, and acetyl-CoA carboxylase again causing carnitine palmitoyl transferase increase, therefore beta oxidation and ketone production increases, essentially causing euglycaemic decay. So next most important question is, which fluid do we use? So plasmalite 148 versus 0.09 saline, which was done by Shua et al. In 2012. What was, sorry, give me 1 second, my charging. Yeah. So what did I notice was plasmalite had faster initial resolution of metabolic acidosis and less hyperchloremia. This is very important to remember. There is a transiently improved blood pressure as well and improved urine output. And second thing is resuscitation with balanced electrolyte solutions can, second study which is done by Mahler et al., where they have done resuscitation with balanced electrolyte solutions like RL, what they noticed was it can reduce what do you call resuscitation of DKA in patients with balanced electrolyte solution, results in lower serum chlorides and high bicarbonate levels than patients with NS. So it helps in prevention of hyperchloremic metabolic acidosis. So these 2 points are to be noted, because then again comes another conflicting study. So not this one, I'll tell you later. Then the fluid management in diabetic acidosis, like RL versus normal saline again, which was done by Van Zyl et al. In 2012. This study failed to indicate benefit from using RL to 0.9% NS regarding time to normalization of pH. What they did realize was the time to reach blood glucose levels of 14 millimole or 200 milligram per deciliter took significantly longer when we were giving RL. So from these three studies, what we noticed was plasmalite seems to be the best solution. But what we also need to be looking at is the cost of plasmalite versus NS when it comes to giving bags and bags of the medication. Now, this was the recent study. It was published by Messina et al. It was published in Jan 2025. So the study paper was revisiting DKA fluid management. Should normal saline be used? What they found was completely different. So what happened is numerous guidelines recommend isotonic normal saline as the initial fluid of choice with the DKA. What they have seen is we demonstrated what they say is they demonstrate a great incidence of NAGMA, that is non-anion gap metabolic acidosis after DKA anion gap closure. So there is an increase in time on insulin drip. So people who were given normal saline, there is a great incidence of NAGMA post DKA correction, anion gap closure, and there is also a longer need for insulin drip here. But this is the latest study, and the patients who received 2 or more liters of isotonic NS had longer ICU stay when compared to the patient who received no NS. So these results suggest that balanced crystalloids are better, such as lactated ringers, in lieu of normal saline, especially for initial large volume resuscitation. But this is a study only. This is not a guideline. So now we'll look into the guidelines as recommended by JBDS, that is Joint British Diabetic Society IP. So what is happening is these are the rough guidelines. So reduce the rate of insulin infusion to, more important, see, I will start off with zero point 0.1 units per kg per hour. But as soon as sugars are less than 200 or 14 millimole, get it down to 0.05 units per kg per hour. And whether we give colloids or crystalloids, 0.9% saline, rate of fluid replacement, IV bicarbonate, use of IV phosphate, and what should be the rate of glucose lowering. Okay, these are the things we will look at this point. Give me a minute. So how much do we reduce this thing? Colloid versus oh,
Dr. Satish, sir. I think the speaker got disconnected due to some internet issue. We'll wait for a few minutes.
Hello, everyone. I think the speaker got disconnected due to some technical glitch. Let us wait for some time so that he can reconnect to us.
So we'll be reconnecting in just 2 minutes.
Hi, sorry, there was a sudden system issue and I lost the connection. So going back to the recommendations of JBSP, JBDS guidelines. So we were, hey, 1 second. Yeah, so we were at whether about we can give colloids versus crystalloid. Am I audible, Dr. Satish?
Yes, you are audible.
Okay, sorry for the interruption, everyone. We'll be resuming. So regarding colloid versus crystalloids, there was a 2007 study that was done. So there is no there's no role where you can use colloid over crystalloid. So it is absolutely a no-go there. And regarding 0.9% sodium chloride versus balanced crystalloids, again, what happens is when we give let's discuss about advantages and disadvantages of 0.9 versus, normal saline versus balanced electrolyte, that is ringer lactate. So advantages of normal saline is it is proven for decades. There's a lot of evidence based on normal saline, and it is readily available in most areas, and it is commercially also easily available. And second thing is it supports safe practice guidelines as per NPSC. But there is a disadvantage, that is it can cause hyperchloremic metabolic acidosis. It can cause renal arteriolar vasoconstriction, and it leads to basically slowed down reduction in acidosis. Next thing, but the advantages of RL is it is a balanced electrolyte, so therefore the chances of electrolyte imbalances are lower, and there is a lower incidence of hyperchloremic metabolic acidosis. But there is a disadvantage. Basically, insufficient if it insufficient potassium if it is used alone, and you need to anyway supplement potassium later on. So it is not commercially available everywhere, and it is unfamiliar, not routinely kept in departments sometimes, right? And regarding the intravenous bicarbonate, which we have already discussed, there is minimal role for intravenous bicarbonate. And what about intravenous phosphate? So phosphate concentrations are often done as a standard when there's a when bone profile is requested. What happens is, despite initial serum concentrations appearing normal or significant intracellular depletion, what happens is it averaging about, I'm sorry, 1 millimole per kg, even if we give it. So what happens is there's not much outcome. Outcome is not what do you call, dependent on giving intravenous phosphate. It does help a little, but what it essentially says is there is a very low benefit with that. And most important questions would be, what would be the rate of lowering glucose? So we know that we'll be this thing using what do you call, insulin infusion at around 0.1 units per kg per hour. But what we need to discuss is, even if high dose glucose insulin are given, and then glucose levels are coming down by about 50 to 60% in first 4 hours alone, that there is a theoretical risk of large osmotic shifts due to rapid changes. But it is usually rare. There is a theoretical documentation, but it is not common. So therefore, we can happily give 0.1 units per kg despite the rate at which it is lowering down, until it is below 200 milligram per deciliter or 14 millimole per liter. So what are the complications of DKA and its treatment? So depending on how we are treating at that point of time, it can cause hypokalemia and hyperkalemia. And another complication of treatment of DKA is hypoglycemia. And another complication of especially seen in younger group is basically cerebral edema due to large fluid administration. This is more common in young adults. So we look at two special considerations, again, in end-stage renal failure and patients who are on dialysis, and in pregnancy. So what happens in dialysis? So in dialysis, what happens is there is a inability to develop osmotic diuresis. So therefore, dialysis-associated hyperglycemia and ketosis can occur without much dehydration. So essentially, what we are trying to say is there is not much dehydration in patients presenting with, patients who are on end-stage renal disease or dialysis. So therefore, do not look at as hydration as normal. But if we do feel there is a dehydration, frequent clinical reassessments will help us with some minimal boluses like 150 to 250 ml can be used, and up to like aliquots up to 250 ml can be used. And then when you go for insulin treatment in DK, again, for insulin replacement remains the same, the dosage does not change. But what is advantageous here is you don't need to worry too much about potassium, because there is a lower chance of hypokalemia, especially in patients with CKD. But yes, keep monitoring potassium. And these are the things you need to look at with insulin. Insulin and potassium in DK in DK in renal failure patients. Regarding pregnancy, it becomes an emergency. So it can present patients with gestational diabetes can present with abdominal pain. Make sure you differentiate it from preterm labor or term labor. So that needs to be looked into. And DKA can easily occur with even very minimal elevations of sugars. So you have to keep a very low threshold. So the symptoms remain same, like nausea, vomiting, abdominal pain. These are the things we look at. And usually what happens is there can be poor outcomes, so need to be handled well. And we need OBG and pediatrics intervention while handling pregnancy related DKA as well. And any specific investigations can be consulted with OBG to be as and when required. So final step, we'll be discussing the DKA pathway of care. So the first 0 to 60 minutes, see what are our aims and what are our actions. These are the first 0 to 60 minutes. Usually the patient is in the emergency department. So we need to commence IV 0.9% sodium chloride. We start a fixed insulin rate regimen, and then we establish an appropriate regimen for diabetes. So generally what we do is hourly ketone measurements and 2 hourly glucose, 2 hourly serum blood or potassium and bicarbonate in the first 6 hours itself. And a clinical and biochemical assessment of individual has to be done to look into any triggering factors for decay and involve the diabetes specialist team as early as possible. And another action is these are the aims. So action 1, as with any emergencies, we immediately go for rapid airway breathing and circulation assessment. Secure at least 2 IV large bore cannulas preferably. Clinical assessment needs to be done. Respiratory rate, temperature, blood pressure, pulse, oxygen sats, everything has to be monitored. GCS needs to be documented clearly. A drowsy individual in case of DKA is serious and therefore requires critical care assessment, and if required, involve critical care as soon as possible. And if required and if clinically warranted, go for a nasogastric tube, that is Ryle's tube. And if required, if the person is obtunded, consider airway protection to prevent aspiration, and full clinical examination needs to be done. So initial investigation should include blood ketones, capillary blood glucose, venous glucose, plasma glucose, urea and electrolytes, venous blood gases, full blood counts, blood cultures, ECG, chest radiography if indicated, urinalysis and cultures if indicated, continuous cardiac monitoring, continuous pulse oximetry. You have to look into precipitating causes as soon as possible, because the sooner we reverse precipitating causes, the earlier we can get it better. And we have to establish usual medication for diabetes, they usually take, and what could be the triggering factors, like we have discussed SGLT2 drugs. Pregnancy test has to be done in patients or in women with childbearing age. That is very important. Action 2 in step 1 itself, again, restoration of circulating volume has to be started as quickly as possible. So we need to assess the severity of the dehydration, pulse and blood pressures. As a guide, 90 millimeters on MAP 65 can be used. So, but take always multiple factors into consideration, like age, gender, concomitant medications and all. So if the BP is below 90, hypotension is likely due to low circulating volume, but consider something like sepsis and heart failure as well. So what we need to do is the standard protocols, again, adhere to sepsis guidelines if we are suspecting sepsis, heart failure guidelines if same thing. So essentially we start with IV fluids and keep monitoring BP, and you also take seniors help or specialist help if required. 5 to 100, 1 liter, half liter to 1 liter can be given. Get the critical care team involved as soon as possible. And as soon as BP is above 90, we need to start fluid replacement. So this is roughly over. We are considering an average adult of 70 kgs. You can see the first 1 liter has to be given over 1 hour, and then 1 liter has to be given over 2 hours. But you can notice from second hour onwards, we are starting potassium chloride about 30 to 40 milliequivalents. Do modify the dosage according to the potassium. Keep monitoring potassium every 2 hours, like we have discussed. So 1000 ml over next 2 hours and the next 2 hours. So basically next 4 hours, there will be 1000 ml per 2 hours. That is 500 ml per hour. And then next it becomes 500 ml per 2 hours. That is about 250 ml per hour for the next 4 hours. And then again, another 250 ml per hour or 1 liter over next 4 hours. And then the next 6 hours will be including another 1 liter. But again, please make sure there is a repeated clinical assessment to see that you're not overloading the person with fluids. And if required, keep changing potassium chloride as and when necessary. Exercise caution. These are, like we have discussed, young people between 18 and 25. You don't want to cause cerebral edema. Elderly people, they can be having some concomitant conditions. You need to look at pregnant people, people with heart or kidney failure, and any other serious comorbidities that needs to be considered. Action 3 and action 4 essentially include potassium replacement and fixed rate infusions. And then the next step is 60 minutes to 6 hours, by which time this part of it will be happening in emergency department, part of it will be happening in the ICU. Get them quickly as soon as possible to ICU. So what are the aims here is, we need to clear the blood of ketones, and we need to try and suppress ketogenesis as much as possible. We need to achieve a rate of fall of ketones of at least 0.5 millimole per liter per hour. And in the absence of ketone measurement, what you can do is you can target bicarbonate should rise at least 3 millimole per liter per hour. And second thing is blood glucose also should need to be falling by at least 3 millimole, or that is about 50 to 60 milligram per deciliter. And maintain serum potassium, try to maintain that in the normal range. Try to avoid any hypoglycemia. And consider shifting to ICU as soon as possible. Actions, again, the same thing. Patient needs hourly monitoring of sugars need to be done, ketones need to be done, urinary catheter needs to be placed, make sure that is done, and we need to monitor the output. And again, nasogastric tube, oxygen saturation should be continually monitored. And if O2 is falling, instead of VBG, consider ABG and arterial blood gas, and make sure early warning scores are being charted appropriately. Continuous monitoring of GCS levels, and if it drops, urgent brain imaging can be considered in view of cerebral edema because of the fluids we have been giving. And maintain accurate fluid balance chart. The minimum urine output should be 0.5 ml per kg per hour. And continuous cardiac monitoring needs to be done with severe DKA patients. So next 6 to 12 hours, this mostly happens in the ICU. So what here is aim is we are trying to ensure that the clinical and biochemical parameters are improving at the correct rates. IV fluid replacement is going on, insulin administration is going on, tapering as in necessary, but it is usually 0.1. We need to continue 0.01, sorry, 0.1 units per kg per hour until it is less than 200. And assess for complications of treatment like fluid overload or cerebral edema. Continue to treat any precipitating factors like sepsis or strokes or any other factors, and try to avoid keep monitoring vital signs. We review the biochemical markers and the metabolic parameters. At 6 hours, we make sure we check venous pH, bicarbonate, potassium, basically a blood gas, as well as blood glucose and sugar, this thing, ketones. Resolution of DKA is defined as ketones less than 0.6 millimole per liter and venous pH over 7.3. Please make sure that is not achieved by using bicarbonate, because at this stage, because hyperchloremic acidosis associated with large volumes will lower bicarbonate levels as well. So the same thing in a flow chart, we can look into this. Actions. So one last modification, I'll just give me a minute, I'll show you. So I hope you can see my screen.
Yes, we can see your screen.
Yeah, so this is the pediatric guidelines. So what we need to do is this is an algorithm if it is person is less than 18 years of age. So again, what are the clinical history? Same, typically change, nothing changes. Polyuria, polydipsia, weight loss, abdominal pain, weakness, vomiting, confusions,
Dr.
dehydration,
Nikhil,
small breathing, all this. Sir, you're saying something, sir?
yeah. Actually, we are looking at the last slide of the previous presentation.
Okay. 1 second, sir. Oh, you're still looking at that. 1 second. Better, sir?
No, it's the same slide.
1 second. Why is it paused? Sharing minus, it shows pause, sir. Give me a minute. Oh, yeah. Okay. Is it better now? It's visible?
No, I still see the same slide.
Sir, you have to reshare it, sir. We'll just cancel it and reshare it.
1 second. Sir. Done. This is the pediatric guideline.
Yeah.
So this is for young people under 18 years of age. So clinical signs, again, dehydration, small breathing, lethargy, drowsiness, and the similar thing, pH less than 7.1 would be, in case of pediatrics, 7.1 becomes severe DKA. Consider around 10% dehydration at least. Less than 7.2 moderate DKA, less than 7.3 is mild DKA. So biochemistry wise, again, hyperglycemia more than 11 milli, nothing, the criteria remains the same. But when you look, most important thing is tachycardia, prolonged central, we have to look at capillary refill time, poor peripheral pulses. So if any of these signs, hypotension is usually a very late sign in pediatric group. So resuscitation, the change, airway, breathing, circulation. In circulation, we give 10 ml per kg bolus of 0.9% chloride or plasmalyte 148, and repeat until circulation is restored. By usually 40 ml per kg, you have to involve pediatrics, senior consultant, and pediatric intensivist. right? If the patient is not in shock, we can give slow boluses of 10 ml per kg, 0.9% sodium chloride or plasmalite over 30 minutes instead of boluses. So these are the IV therapy. You can use DK calculator at co.uk and use fluids as required. And we start insulin as at 0.05 or 0.1 units per kg per hour for 1 to 2 hours. After starting fluids. Okay, so what are the signs? We look at early blood glucose monitoring, 1 to 2 hour blood ketones monitoring. Early neuro observation has to be done. Again, these are similar to what we see in adults, but features of cerebral edema needs to be closely monitored. So what do we see? We look if the person is or the kid is getting irritable, if there's any headache, if the heart rate is slowing drastically, yes, that is another sign of cerebral edema because it is a sign of raised ICP, and reduced GCS or comatose or upturned state, that is a sign of cerebral edema. Then signs of raised ICP and that is increased blood pressures, and others are on care pathway. These are things we need to look at. So if acidosis is failing to improve, we need to reevaluate our fluid balance and require more resus fluid and check if insulin is running properly. So consider sepsis and other differentiations and consider restarting the protocol all over again. If it is improving, it is fine. If cerebral edema are there though, we need to start 5 ml per kg of they say 2.7% sodium chloride, and we don't have 2.7% sodium chloride in India. We have 3% sodium chloride, so we can give around 5 ml per kg, or you can give 20% mannitol at 2.5 to 5 ml per kg. Involve the senior pediatrician, restrict IV fluids by more than 50%, and we need to get him care pathway again needs to be looked at, reassessed continuously. If glucose is falling below 14 millimole per liter, we need to change fluids to containing 5% glucose instead of normal saline, and that is basically 5D and or dextrose normal saline. We can use that, and if glucose is falling below 6, we need to change fluids to 10% glucose, that is 10D, and do not reduce insulin below 0.05 units even until ketones are normal. So you have to make sure ketones are being monitored. And if the glucose falls below 4 millimole per liter, that is around 60 to 70 milligram per deciliter, you have to keep again revert back as to give what care is required. So this is regarding the DKA management. So that will be the presentation. Thank you. Any questions? I'm sorry it went too long.
Okay, thank you, Dr. Nikhil. That was a very interesting and elaborate, very detailed presentation. We
It's
learned
okay. Thank you.
lot of points today. Like fluid management is the most important thing in the DKA management.
Yes, sir.
Okay. So now we move on to the forum for any discussion on question and answers. Just let me look at any question and answers section.
Yes, sir.
There are no questions in the
Seems like yes, sir.
section. Okay. Anybody is having questions? I think nobody's having questions, so they might have
sir.
understood very well.
Or very few people. Yeah, right. Thank you, sir.
Yeah. Thank you, Dr. Nikhil, once again.
Thank
If
you all.
nobody's having any questions, let's close the presentation here.
Sure, sir. Right.
Yeah.
Thank you.
Thank you. Thank you.
How do I stop?